So greetings everyone once again, and welcome to the 119th session of the online Optom Learning Series, or OOLS. And for today's session, we have with us Madam Karen Walsh. She is the Professional Education Team Leader and a Clinical Scientist at the Center for Ocular Research and Education. She is based in the University of Waterloo, Canada. She has a previous experience working as a professional affairs manager in the contact lens industry, and also she has been into a clinical practice in the UK. She holds a postgraduate diploma in clinical optometry from the City University in London. She has a couple of fellowships to her credits, a fellow of the American Academy of Optometry, a fellow of the International Association of Contact Lens Educators, and also a fellow of the British Contact Lens Association. She also has an extensive experience in delivering education with many aspects, particularly in terms of anterior eye, contact lenses, and dry eye. And with all that experience, she is going to talk to us about the effective management, which is the lid management in terms of patients with dry eyes and also contact lens wearers. So welcome, ma'am, onto our platform, and let me just leave the screen time to you.
Thank you very much. Lovely introduction, and appreciate the invite to come and talk to you, and thank you for tuning in this evening. I did just smile actually with that introduction. You're right about talking more about anterior eye things in the last number of years of my career. I may have forgotten what a retina looks like. So there's many of you listening that could point me right in the right direction for further back in the eye these days. Yes, we're talking about anterior eye today. We are thinking very much about the eyelids, Meibomian gland dysfunction, or MGD, of course, but really anything to do with the meibum and those lids just not working properly to create the lipid layer on the tear film. And just to start off up front, what do I hope to get out of this for anyone listening today, or hope that you can get out of this? Not rocket science, but I'd like to be able to leave you with a really positive feeling that we can do so much more for both our dry eye and our contact lens wearing patients in terms of helping their comfort by much more proactively assessing their eyelid margins and then advising the right kind of therapies and ongoing management these days compared to many years ago. And I know when I was in practice for a decade, looking at eyelids proactively when there didn't seem to be very many problems was not front of mind. It was not front of mind to push on a gland and check meibum in a contact lens wearer that otherwise seemed quite happy. Those things have very much changed. And if I can help get some of that across to show you that it's possible, nice and straightforward, and we can make a difference for our patients, then that would be great. Okay, so we're going to have a little journey through some of the basics just to touch on and remind ourselves around MGD, dry eye disease, and then how the impact of contact lens wear can affect that tear film and lipid layer too. We'll start with that. We'll have a little look about clinical diagnosis and then move into some of the evidence. And some of that evidence is fairly new, which is why it's important to try and get out and share this stuff for both dry eye and contact lens wearers and how we can help them. So this, of course, is not new. This is sort of, Meibomian gland dysfunction 101. Let's go back to a pretty well-accepted and traditional definition for Meibomian gland dysfunction. Some of the important words I've highlighted here that feel important to me, but the fact that we're talking about a chronic condition, clearly not something that we can treat once for our patient and know that it's not going to come back. So our patient needs to be educated and understand that they're part of an ongoing management process should they present with these kind of changes. We know we're looking at changes to the Meibomian gland duct system and then to the meibum that is produced within them. It alters the tear film, of course. That alteration leads in the end to tear film changes lead to inflammation on the ocular surface and ocular surface disease. We'll see later how those tie in with dry eye disease and the vicious cycle and circle of dry eye disease as well. So your typical MGD suffering patient, and we see some fairly marked examples in those two clinical pictures that you can see on the screen there at the moment, is going to present with, uncomfortable feeling eyes. On first appearance, it can sometimes be very similar, the symptoms at least, to sort of a significant blepharitis kind of situation. Those eyes may feel gritty, dry, uncomfortable. Vision may be fluctuating with the blink, so sometimes more clear than others. Early stages, we know, can be asymptomatic. You may be finding some of the clinical changes before your patient is mentioning any symptoms. That's an important one to be aware of. And I think particularly in contact lens wearers, we'll come on to that later. And then when you get a little closer to that patient, pop them behind the slit lamp by a microscope. Of course, you're looking for inflamed, rounded and hyperemic lid margins. You may see some of those extra little vessels, the telangiectasic vessels that thread away across the surface of the lid margin. You may start to see some of those glands that look capped or blocked on the surface. And then, of course, when you do a diagnostic expression, and again, we'll talk about the detail of that a little later, you're going to see some changes to what should otherwise be clear, oily meibum. Who are you going to be seeing this in typically? Well, it does vary. Depending on some patient factors. So some of the key factors that we know and understand are shown here. There's a variation by ethnicity. It seems to be more common in an Asian eye, for example, than a Caucasian eye. And that's one of the well-known differences. Another very well-known difference, of course, is MGD is much more common as we age. So it's almost more than doubling between the ages of under 30 to over 60, very much more prevalent. It's very common in people who have dry eye disease, and I'll touch on the detail of that 86% figure a little later. You may well have heard that said before, that 86% of patients with dry eye disease have some kind of evaporative or Meibomian gland component to that issue. That's a very well stated fact. And more recent research has been done, it's just about to be published, that actually backs up that figure very nicely. So we do very much believe in that 86% figure. And then the other group of patients to consider, of course, with Meibomian gland dysfunction are your cataract patients, those that are about to be referred for cataract surgery, that might need that surgery. Recent research has showed that about half of them also have signs of MGD. Now, that's important for a couple of reasons, because a disrupted tear film at the point that the biometry measurements are taken before cataract surgery can impact the accuracy of those measurements and impact the particular power of the intraocular lens that's chosen to be replaced when the cataract is removed. It can also impact the outcome and success post-surgery. So if the ocular surface is compromised, the tear film is compromised, then vision and comfort and dry eye symptoms can be worse after surgery than would otherwise be the case. So it's worth looking out for and potentially treating ahead of time any Meibomian gland dysfunction you might see in that cataract group of patients as well. Okay, so what's the process of MGD? Well, we're going to talk circles over the next two slides. It's very much thought that, again, this is a sort of a self-perpetuating, spiraling circle of ongoing condition once Meibomian gland dysfunction is started. You're getting blocked glands which start to drop out as well over time. Within those glands, we understand that the microbiome starts to change, and there are an increased amount of microbes that sit in those glands. That, in turn, we believe changes the consistency of the meibum that is sitting in the glands, making it thicker, making it harder to get out of the gland. So it sits in and it gets kind of stuck and stagnates in there. That's releasing, then, we believe, enzymes that initiate an inflammatory response. And we know those lids end up looking very inflamed over time. Now, eventually, that gets released onto the ocular surface and starts to irritate the ocular surface. And we believe that we're starting to get then death or apoptosis of cells and changes to the lining of the glands, where they get keratinized and become sort of thickened and scarred over. That dropout leads to more dropouts, and we start to get that cycle. Now, how does that fit into dry eye disease? Well, it's thought, of course, that they're pretty synonymous. There's an enormous overlap, and one feeds into the other. But if you can imagine that your Meibomian glands are responsible for producing the lipid layer of the tears, and if that lipid layer is significantly compromised because the glands are dropping out, because the meibum cannot be produced at its normal expected consistency and be allowed to come out onto the tear film, then the tear film is disrupted. And if the tear film is disrupted, we get increased evaporation, and we're into the dry eye cycle. So that's our blue inner circle that you see that I've just brought up here. So the lipid layer leads to increased, or reduced lipid layer leads to increased evaporation, to an inflammatory response on the ocular surface, leads to the keratinization of Meibomian glands, and again that sort of feeds into that cycle as well. And this is very much trying to describe and trying to fit together the process of MGD and its chronic progress into what we also know with dry eye disease. And when we look at dry eye disease, and I'm sure many of you will have seen the TFOS used to definition from the 3-4 years ago now. But it's describing here for dry eye disease a loss of balance of the tear film, that homeostasis, leading to that instability in the tear film I just described. That in turn raises the osmolarity of the tear film, which sets off that inflammatory response as well. And we get some neurosensory abnormalities as well. So these two sort of really feed into each other. And again, it's no surprise then that we start to see, and we're coming back to that fact about how common MGD is within our dry eye disease population. There's no surprise that really is the case. And what are you looking at here? Well, you're looking at a data set from just over 200 patients with symptomatic dry eye disease, and they were classified the type of disease they had. Now, this was pre-TFOS use. They would have been using slightly different definitions and classifications. But you can see here that for pure aqueous deficient, we know that that's a relatively small amount of dry eye disease. And in this study, it was just 10% of patients. Now, the rest had either something that was lipid, potentially a mixed disease, which of course is very common, as we do understand. So something of aqueous and something of a lipid deficient problem. And you can see that about a third or just under were kind of unknown really what was going on, or they were definitely symptomatic of dry eye disease. Now, of those that were classed and classified with mixed or aqueous deficient or lipid deficient, so when the type of their dry eye disease was known, of those, 86% had signs of Meibomian gland dysfunction. So that's where we get that figure from. And as I say, I have been told by a global-based researcher that they've redone a similar study more recently and found a very similar proportion of MGD in dry eye disease. So when you're seeing someone with dry eye disease, what's your takeaway point here? They are more likely than not to have some kind of changes with their Meibomian glands. I think that's the clear, simple takeaway point. Okay, so that's your dry eye disease population. What about your contact lens wearers, and where do they fit in? Okay, well, let's have a little think about, these are my diagrams. I'm not an artist, so this is like, we have to say, what do we say? We'll say that this is an artist's impression. This is not an accurate diagram. But what am I trying to show you here? So the little kind of turquoisey areas at the bottom of this slide are the cells and epithelia of the cornea. To imagine a little glycocalyx there. And then that slightly darker blue line is meant to represent the tear film. The tear film is a very delicate structure. It's very thin. We know there's not a large volume of it on the surface of the eye. Well, what happens when we put a contact lens in? Let me show you. Now, that kind of greeny turquoise large element that just rose up there is meant to represent the contact lens. Now, that looks extraordinary, doesn't it? But we need to break this down because that's kind of what's happening. The tear film in an eye with no contact lens in the normal eye, is about, in the center of the tear film, we think 3 to 6 micrometers thick, microns thick, as in it's very, very thin. Your average soft contact lens that you put in is about 70 to 100 microns thick. So you are at least 50 15 times thicker with the volume of that contact lens that's going into the tear film than the original tear film itself. So what on earth does that do to the structure and function of the tear film when you're wearing a contact lens? Well, we know it splits things apart. So you end up, of course, with a pre and a post tear film around that contact lens. But we also know other changes will happen as well, because it reduces the overall thickness of the tear film by doing so. Significantly, it disrupts and thins the lipid layer. Now, I've just described an abnormal and disrupted lipid layer from Meibomian gland dysfunction in our dry eye disease patients. Well, wearing a contact lens also disrupts the lipid layer as well. So there's some synergies here with changes to the lipid layer potentially being caused by something. We know also then that physical presence of the contact lens, that disrupted lipid layer contributing as well, will reduce the tear breakup time. So that tear breakup time when a contact lens is in over the front of the contact lens is significantly shorter, of course, than when there's no contact lens in the eye at all. And we can see an example of that here. And this is actually my eye. I'm a high myope. I wear monthly soft silicone hydrogel toric contact lenses. And it's a little jumpy on the video here, but really immediately after the blink and the eye is open, you can see the mires on that placido disc that's reflected in the tear film already looking uneven in places and breaking up. It doesn't take long, more than a couple of seconds, for that tear film on the front surface of my eyes to start collapsing in between the blink. What else is happening with our contact lens wearers in terms of changes or things that are relevant to the Meibomian glands? Well, this is only one slide to summarize a very debatable area of research at the moment, and we don't really have clear answers for it just yet. And that's the question over whether wearing contact lenses affects the Meibomian glands themselves. So right now we have conflicting evidence. We have evidence on things that have been published on both sides of that argument, saying that by wearing contact lenses, we start over time to see changes to the appearance on meibography of those glands. They maybe start to drop out, look shorter than if you didn't wear contact lenses. There are some studies that say that happens quite quickly within the first couple of years of contact lens wear, and then it seems to stabilize after that. There are a number of equally other studies that will say, no, we haven't been able to correlate those two things together, and we're still not sure really what is happening with Meibomian glands appearance on meibography in our contact lens wearers. So for that at the moment, the jury is still out. What is fairly consistently known is that the meibum secretions in contact lens wearers do look different to a non-contact lens wearer and do change over time. So there's definitely something going on and some association. And it's not surprising given what I was just describing about that physical presence of the contact lens. But this is an area that it's worth keeping up with the research over time. And for now, in your clinical practice, what do you need to know? Well, I think be aware of noting your Meibomian gland and lid margin appearance in your contact lens wearers and watching for changes over time is important to do and relevant anyway. So keep on doing that. If you happen to have access to a meibographer, it's great to take pictures at baseline when you're fitting a patient and follow that up over time. But we have more to find out on this for sure. Now, of course, what's the importance of making sure our contact lens wearers are happy? Dry eye disease is one entity, and we know we need to tackle and treat that in those patients who suffer from it. And contact lens discomfort, that mild irritation. I can wear my contact lenses, I'm just not that happy with them after 12 hours of wear. I take them out a bit earlier. Well, CLD, or contact lens discomfort, has been defined very well in the TFOS Contact Lens Discomfort Report 2013. And more recently, actually, we're starting to see a review of those kind of parts of the evidence with the BCLA CLEAR reports that were published just in April this year. But in that TFOS report, there was a nicely described process for contact lens discomfort and what that leads to over time. So we know, of course, if a lens is not so bad that you have to take it out and you can't wear it, but if it's just not quite performing for a patient for comfort for as long as they need, they become aware of it at some point during the day, then slowly and quietly over time, the reason I say quietly is it's often not enough of an issue that the patient will come into you and and ask for help. They just sort of think, oh, I can't wear my lenses for as long. They'll start to wear them for fewer hours through the day, fewer days in the week, maybe start to get used to glasses a little bit more. And eventually that process we know leads to dropout. So it becomes very important to try and catch this early on. So this is one of those reasons for being proactive with contact lens patients, and not just kind of saying, when you see them for aftercare, is everything okay? But you really need to go into depth of, well, how long do you wear your lenses for? Give me the time you pop them on, time you take them out each day. Of that time, how long can you wear them for comfortably? Now, if there's a gap of more than 2 hours between those two answers, so if they're wearing their lenses for 14 hours, but they can only wear them comfortably for 9, and the last 5 hours they become aware of them, that's a warning sign for going through this process leading towards dropout. And it means it's a great opportunity for you to go in there and look and see whether a change in the contact lens, care regime, or anything to do with their eyelids and tear film can be done to help improve their situation. So it's important to catch. Now, one thing I just wanted to draw a distinction between here is, well, can contact lens discomfort and dry eye disease exist together? Well, that's an interesting question, because the strict definition of contact lens discomfort is that it's a sensation and an awareness of symptoms only when the contact lens is worn. So as soon as the contact lens is taken out, that person becomes asymptomatic. Their eyes go back to feeling normal. We've all had that experience if we're contact lens wearers. So that's the strict definition of contact lens discomfort. Now, the strict definition of dry eye disease means a patient has to have symptoms of dry eye themselves, and that's the first gateway to being diagnosed under the TFOS GUS2 guidelines. So you have a dry eye disease patient who has to have symptoms all the time, and a contact lens discomfort situation that only occurs with the contact lens in the eye. So by definition, they are two completely separate groups of patients. But I'm sure many of you listening are thinking, that's not true. That's not the case. And absolutely no, of course it isn't, because we've all seen them in our clinics. We know that the two can coexist. So it's quite possible to have someone with a sort of mild and low level of dry eye disease, or early stages of that, or Meibomian gland dysfunction, that may have some dryness in their eyes without their contact lenses in, that occurs at various points through the day or at the end of a long day. And that same person could still pretty successfully wear their contact lenses and probably experience some contact lens discomfort towards the end of that day as well. So do be aware that those two can cross over, particularly, of course, at the mild end of the spectrum of dry eye disease. Okay, so that's sort of that background bit. But what are we doing in clinic to check out and find Meibomian gland dysfunction and Meibomian early changes in our patients? Well, it's nice and straightforward, and I think I want to emphasize it doesn't take any extra sort of expensive or sexy equipment. We hear a lot of things about, it's nice to have all these extra pieces of equipment, and if you do, fantastic, because it really can enhance your practice, and it can really help with educating patients on showing them what you've seen, if you can show digital images of what you've seen, for example. But the point I want to make is you don't have to. Okay, you can do all of these things with a fairly normal clinic setup. So that's really good news. The MGD diagnosis sort of algorithm laid out here on the slide actually is not significantly different to TFOS GUS2 for its dry eye disease diagnosis. There are an awful lot of similarities, which is good, because again, we can be applying similar thinking when we're seeing our patients. They start off with a symptom questionnaire recommendation. Now, in TFOS GUS2, we know that we've got the DEQ5, the Dry Eye Disease 5 questionnaire, or the Ocular Surface Disease Index, OSDI questionnaire, are the two recommended ones. There is some research to say that the SPEED questionnaire, if anyone's familiar with that, is a little better or a little more sensitive to Meibomian gland changes rather than, or evaporative dry eye changes rather than aqueous changes. So some people prefer to use SPEED, but honestly, if you're not using a questionnaire at the moment, the first piece of advice is to find one, and all of those three are available readily on the internet. The first two I mentioned you can find on the TFOS Use 2 website and download for free. The speed questionnaire you can find on our own educational website, which is contactlensupdate.com. You can sign up with your email address to receive one of the 6 editions that we bring out every year. Every other month we bring them out. But the speed questionnaire is available for download on there. So you can access them for free, print them off. And if you're not using anything, the first piece of advice is just to use a questionnaire, because it really starts to give you a quantified and measured amount of symptoms of that patient, which you can match up against known values, whether they have any mild, moderate, or significant disease. And it allows you to track their symptoms over time. Now, that's super important, because with these chronic conditions, it can often feel to a patient like they're not making any progress, right? It can be quite hard to live with a moderate to severe dry eye condition, and quite demoralizing, quite kind of, it can make you feel like you're not making any progress when you keep coming back in and saying, well, my eyes are still dry and sore. At least with the questionnaire, you can start to measure from visit to visit how they're doing. Are they getting better, holding at about the same level? Are they actually getting worse? And so you get to put a number on it, and it's extremely helpful with more accurate management of your patients. After symptoms with this particular patient, you're going to look at tear breakup time. You would do the same if you're analysing for dry eye disease anyway. And then you're going to move on to ocular surface staining, and then look at the lid margins, and then express some Meibom, importantly, from those glands. So I'm just going to take you through some examples of those. So the ideal for assessing the tear film quality, so it's how long it's going to stay there, its integrity, how stable it is on the surface of the eye. The ideal recommendation is to do that with a non-invasive technique, of course. So you see here an example. This is taken from the Oculus K5. And between the blink, you're asking the patient to hold their eyes open. Some of the examples of instruments here will have software where they will automatically pick out the breakup point for you. Other times it's easier or more preferable to watch yourself and mark the number of seconds it takes. And ideally, particularly for research, we would do that 3 times over and average that result. Now, these kind of non-invasive instruments for measuring tear breakup time with a Placido disc that can be reflected onto the tear film, not available in every practice by any stretch. They may be in some of the more academic or hospital situations. So if you don't have that, doesn't mean that you can't assess tear film quality. You're going to be instead using a fluorescein dye. Put a minimal amount in, so shake off the excess if you have it on a little fluorescein paper strip that you've wet with saline. You don't want to put too much in, so shake off the excess. Put the minimal amount in you can, give it a minute or 2, and then go and assess your fluorescein breakup time instead. So yes, it's invasive, but it's certainly better than not doing it at all. So you've got 2 ways of assessing tear film quality. And then, of course, once you've got your fluorescein in, you can also then go straight into having a look at ocular surface staining. And that becomes important to understand both for the cornea and the conjunctiva, whether there are any dry areas there, and noting down by diagram and grading what you're seeing. Some regions of the world have access to lissamine green, which is the last image that you see there. Some don't. Viewed under white light, you can use it with a red-free filter as well. I don't find it adds too much more to my view. I find the green stands out quite well on a white light. But these ocular surface staining recommendations go for both Meibomian gland dysfunction. You're investigating that solely, but also cross over into your dry eye disease diagnosis as well. Now, you're going to want to have a particular close attention to the appearance of the eyelids. So a lower magnification, a diffuse view is a good start to do this. And you can see an example of an eye here. It's ticking quite a few boxes of the kinds of things you might want to be checking for. So you're going to look for whether those lid margins look inflamed or rounded, whether you can see any of those telangiectasic vessels. And in the first image, fairly central in the picture, you can certainly see an example or 2 of those little vessels. How regular is the lid margin? Is it notching? Have you lost any eyelashes along the way? And then can you see any capped Meibomian glands? So that gives you a really good start and a lot of clinical data to note down for that patient about the condition of their eyelid margins, much of which is very relevant later on when you come back to try and treat them. And I mentioned at a few slides ago the importance of doing what we call a diagnostic expression of the Meibomian glands. And it's really important because until you press on the glands, you don't really know what's going to come out. Sometimes those lid margins look pretty good. So you've checked all of the things I just talked through on that previous slide. And actually you don't see so much inflammation or missing eyelashes. You know, there's not a lot to look at in some patients. But yet when you go and do a diagnostic expression and push on the glands and see the kind of condition of the meibum that can get expelled, actually you can get a bit of a surprise. So you always do need to do this. There is a little tool pictured here, actually. It's called the Meibomian Gland Evaluator. It's inexpensive and available, I believe, from Johnson & Johnson these days. It was invented by Tear Science originally. What that allows you to do is that little white part on the end, for those who are not familiar, will depress with a constant pressure against the lower margin of the eyelid. So it allows you to be quite standardized with applying that pressure to 3 points along the bottom eyelid and then watching carefully and it tends to cover about 5 glands, watching carefully for those glands as you gently depress the Meibomian Gland Evaluator against the lower lid margin, the kind of quality of meibum that comes out, or whether any meibum comes out at all or not. Now, there's a scoring scheme that is proposed for this, and I do just draw everyone's attention to this always, that it's a backwards grading system. So we're so used to lower grades when we're looking at hyperemia and, for example, being the low number being good. So if we see hyperemia of 0.5 or 1, we're pretty happy with that. We don't like it when we're grading up at 2.5 or 3. For this particular grading system, it's around the other way. So the good stuff is the higher number. So if you, I don't know why, but it is. So if you press on the glands and everything comes out clear and oily, and there are no issues with any blocked glands that you can see, you're grading each individual gland at a 3. And you do that in your 3 places across 5 glands in 3 places. So you get a maximum score of 45. When you see nothing coming out and the gland seems to be blocked with that pressure and nothing is released, you grade it at a 0. So it's a backwards grading system, but it's very quick to do. What do you do in practice if you don't have a Meibomian Gland Evaluator? Well, there are other ways of gently pressing on the lower lid to have a look at those glands. It could be with a thumb, with permission from the patient. It could be with a Q-tip. And there are some other proprietary sort of little depressors now that are available that you can also use. So find and make sure this is in your routine for both investigating in dry eye patients and in contact lens wearers. And the kind of things that can be coming out, well, ideally the first picture, we don't often see this as much as we would like to, but very, clear, mobile, oily meibum being excreted onto the lid margin. And you can see clearly that can easily get taken up into the tear film and act as the top layer of the tear film, as it should do. And then the 2 later examples on this slide start to give you a more typical experience and example of when we start to see how the glands will look as they become thick and pasty and blocked with that meibum that has changed clearly in its consistency over time. Now you can see an example here of that kind of pressure in progress. I would argue in this video to get that thick meibum coming out of the glands like that, and relatively as easy with that little pressure, I imagine these glands must have been warmed ahead of time, and that's something that we'll come on to for a therapeutic expression a little later on. To get that kind of movement with the thick stuff, you often need a little bit of heat applied to try and melt those congealed oils a little better. I hope no one's having any food while they're trying to watch that. Some people find that a little bit squeamish. Some people love it, I know. I'm in the middle of those 2 things. Okay, so let's move on to treatment. And treatment I'm going to run through in general, which is really related to the sort of the dry eye patient or evaporative dry eye patient with MGD signs. And then I'm going to run on with some more recent evidence that we have for treating these lid conditions, but in contact lens wearers. Okay, so the good news about treatments, and this was a fairly recent review, actually from last year, so 2020, pulled together the evidence from 35 studies looking at trying to treat MGD and the outcomes for that. So the really good news, and this is important, I think, is that it is worth doing something. This review found that all forms of treatment that were evaluated through the separate 35 studies did something, were effective against some of the signs and symptoms of MGD in the subjects in the studies. So take away from this that it is worth doing something when you see it. And that's important because sometimes it can feel, with patient after patient coming in who has a chronic condition with their MGD, who maybe doesn't do all the things you ask them at home, hot compresses, and doesn't follow all your instructions and comes back in again with the same problems, you can maybe start to feel like it's just not worth bothering so much. And I think this gives us as clinicians a really good reminder that it is worth bothering, and we can make a difference if we can find the right treatment and if we can bring the patients along with us so that they understand, their role in ongoing home therapies and management, etc. So do something, that's great. So everything made a difference, whether it was from simple warm compresses right through to in-office instruments and treatment, which we'll come on to. The effect and the length of time those positive effects lasted did vary by the type of treatment that was given. So that in-office thermal pulsation did have the longest lasting effect, but that doesn't mean that we need to start there. And in fact, the review was very pragmatic, very practical, I think, for application to our clinical practices, because it was saying in a mild to moderate MGD situation, when you're seeing those early to moderate changes, you should start your patient with straightforward things. So warm compresses, get that Meibom melting points so it melts, so the Meibom gets more mobile, can more easily come out of the glands, maybe add some eye drops in. But the point was, start simple. And only when those things don't work, or if you happen to start with a patient who has already got a more severe disease, do you need to go and recommend those more invasive and expensive and in-office treatments like intense pulse light, IPL, or the thermal pulsation. So a very useful and practical review paper by Lam et al. Last year. So if you've diagnosed a mid-margin issue and a Meibomian gland problem, what are you going to do to help this patient? What's your next steps to manage it in practice? The first step, of course, is education. And the patient needs to understand what you found, of course, and what you're going to be recommending. But really, I think importantly for something like this, and for all dry eye disease patients, the patient needs to understand that this is a chronic and ongoing and likely worsening condition. And it's so important because I think for so many things that we have wrong with us outside of our eyes as well, it feels like, there's a problem, you have a treatment, maybe take a tablet for a couple of weeks or antibiotic or something, and it goes away and you're cured. And for something like this, the patient must understand that it is chronic. It's not going to go away, but it is positive in such that things can be managed. But if they understand that and understand that they may have a role to play in their own home ongoing management, it can really help with their compliance and adherence to those pieces of advice that you give them, that you want them to carry on doing at home. If they're not on board with that, of course, you tend to find they don't do the stuff at home that you've asked them, and they come back in, they've got worse, and you're in that sort of cycle where things just aren't getting better over time. So patient education is your foundation and starting point. And then you're going to be looking in practice to do a warm compress. So back to that video I showed you earlier, you're not going to get the thick stuff out of those glands really without warming up that oil, trying to melt it and get it mobile a little bit. So you can use a warm compress. There are ones that are available that you can put in the microwave. There are self-warming versions as well that are available if people do not have microwaves. My parents did not have a microwave until about 2 years ago. They're a good example of that. Using a hot face cloth, a flannel or a face cloth just made hot by hot water, has been shown to not be effective in the same ways as a designed warm compress is, and that's because that hot face flannel doesn't stay warm enough to melt the meibum for long enough. It drops off in temperature after a minute or two, and you kind of need 8 to 10 minutes at least of this warm compress laid over the glands to get that meibum moving. Now, if you're going to try and treat them in practice and take them, if they have a more significant issue, to a therapeutic treatment expression of their glands and try and get everything really cleared out as best you can on that day, after you've warmed, you may then just want to, with a little spud, clear down, and you can use anaesthetic on the lid margin as well, clear down and debride the edge of the lid margin. So that can clear that kind of keratinized skin from across the top of the glands. It can open up some of the gland orifices or the openings, and help again with that evacuation that you're about to try and do. So warm first, get everything a bit softer. Anaesthetic can help with comfort along the lid margin. It can also help soften the tissue as well if you have that available. Clean it down, and then you can do some therapeutic expression. I'll give you some examples of how that can be done in a moment to express the glands fully, to try and clear things out while your patient is in the office. And then, of course, because it's a chronic condition, as I've laboured the point, you're going to want to prescribe some ongoing management for home use. Okay, so we see some examples here of those warm compresses. Certainly the middle example on at the bottom there, the little sort of blue squares, that's a self-heating pad. So again, if you haven't got access, or your patient hasn't got access to a microwave, they can be told about those. If you're able to access those kind of options. To clean the eyelids, there's a number of options you can use. You can use just a metal spud to debride the surface of the lid margin, as I've just described. There are lid wipes and other proprietary available cleaning foams and techniques, or something like BlepEx, which again you can dip into a soapy, foamy substance and clean along the lid margin. So there are a number of options for the cleaning aspect. And then for your therapeutic expression, and particularly effective after you've done that warming, as I mentioned, you can use a number of different forceps, particularly on the bottom lid, easier to get access there, to then release the meibum from those glands and give them a really good clean out. And one of the reasons to do that in office before you send your patient back home with their ongoing management for their lid margin disease and their MGD is it gives the patient a really good start into that treatment. So it can give them a lift and an improvement in their symptoms after a couple of days, such that they know it's worth trying, and it can give them a bit of motivation to keep on carrying on at home with their at-home treatments. And that's at-home management. Again, you can send them home with a warm compress, perhaps the one that you've used on them in practice that day with their permission. There are lid wipes and foams for home use. Lipid-containing artificial tears are a great option for these patients. Now, why would that be? Well, of course, if their meibum is not working properly, coming out of their glands, it's not getting onto the tear film, so which means that their lipid layer of their tears is either absent or severely compromised. So adding lipid back in a lipid-containing or a lipid-stabilizing artificial tear can be helpful for these patients. And then there are some pharmaceutical options as well that you can think about recommending for these patients if they are available in your global area of a region of the world where you're working. But omega-3s are a long-term option. It takes a good 3 months or more to start having an effect. And for some patients, it can be up to 6 months before they start to feel the anti-inflammatory effects of those omega-3s. But it is an option for some patients. You may want to add in an antibiotic to settle down some of the bacterial load on those lid margins. And we've got the immunomodulators, which again are available in some regions. So this is Xiidra and Restasis. It's very popular over here in North America, but for example, not so easily available back in the UK where I'm originally from. And then we talk about in-office treatment. So you can express from a therapeutic point of view those glands with a forcep. Warm up the gland and you can do it with a forceps. So back to me saying you don't need the extra equipment. Don't feel you can't do this if you don't have the extra equipment. But what is the extra equipment? Well, you may well, of course, have seen these examples. So Lipiflow or iLux are both what we call thermal pulsation devices. So they're in office for use with the eye care practitioner using them on a patient. Lipiflow does both eyes at the same time. You sort of plug the patient in, or it can do both eyes at the same time. It takes about 12 minutes. It warms up the Meibom under that kind of actuator, as they call it, and then it starts to move and squeeze the Meibom out. So it's almost like a little spa visit for your eyes. iLux is a handheld device. The practitioner will work around the top and bottom eyelids of both eyes. But again, it does the same principle in the sense that it initially warms for up to 90 seconds, or can take less than that. And then there's a pulsing that the practitioner is in charge of button that you can push against the lid margin to try and evacuate your melted Meibom. So when we say thermal pulsation, we're talking in-office procedure, not at home. And these kind of examples. And this is a popular area right now. There's so much focus on things that we can do to help people with lid margin issues, but we're also starting to see new products coming onto the market as well. So again, something like TearCare has disposable little sort of strips that stick onto the top and bottom eyelid that heat up, and then from there you would do your own expression afterwards. And the same with MiboFlo as well. So MiboFlo again applies heat it needs a gel in between, like an ultrasound gel in between the probe and the eyelid, but it applies heat, and then you can go and express at the slit lamp afterwards as well. And I just give you this last example, which was that'll be an example I know of that's for at-home use, which gives you, rather than just using the proprietary kind of heating bags from the microwave, but this actually provides you some steam as well. So this is an at-home heat system, which again, for some patients can be helpful. Well, do these things work? I mean, there's certainly investment for practice. Do they work? Well, the weight of evidence sits with Lipiflow because it's been available for the longest time. And absolutely, and we go back to that review paper that says the longest effect was with the thermal pulsation. And we have evidence from use of Lipiflow that there's still, after one application of Lipiflow, at the 12-month mark, those patients still had a significant improvement in signs and symptoms. So absolutely, it can be worth doing. It very much does make a difference to patients. IPL is another treatment that's being used an awful lot for MGD patients as well. Again, a review coming out last year of 10 studies. 8 of those studies did IPL followed by manual expression. So again, we still need to get the Meibom out of the glands, but found an improvement in signs and symptoms by using that technique. IPL needs repeated visits. So these were typically treatments done every 2 to 4 weeks across at least 3 visits. And the effect was cumulative up to about 6 weeks. So we don't have evidence right now for much longer effect with IPL. More research needs to be done, but certainly can make a difference. And outside of treating on the eye, if you take Demodex, out of the eyelash follicle, put them on a glass slide and zap them with IPL, it's not surprising to find out that it's effective at killing Demodex in that situation. Again, we need to be able to prove that in vivo on the eye. Okay, so I said I'd talk a little bit about contact lens wearers, and this is the last thing I'm going to touch on. Specifically in contact lens wearers with lid problems, we should be aware because we can make a difference, and this is important. So we may have a fairly happy contact lens wearer, slight discomfort issues, slight Meibom changes. We can get in there and do something now, be much more proactive than I ever would have been in practice. If we ask them to use those warm compress masks, we can make a difference. This study showed that a mask used for once a day over 4 weeks significantly improved the symptoms in symptomatic contact lens wearers. So we can get our contact lens wearers to do this. We can also clean up their lid margins. This study used the BlepEx exfoliating device, and it made a difference in the clinical signs that were visible for Meibomian gland dysfunction and blepharitis in these contact lens wearing patients. But also that same study looked at the load of bacteria after one treatment from BlepEx and found that the bacterial load was reduced, and that the symptomatic patients were reduced in number. And in fact, 10 of the patients became asymptomatic through that process as well. So again, cleaning lid margins can help our contact lens wearers achieve better comfort without changing the contact lens. It's worth bearing in mind. We've also had evidence published that said use of those drops that contain a lipid, and in this case it was pre and post contact lens use, so twice a day when the lenses were not in, again can help symptomatic wearers. There's a further follow-up study to this one just being published as a poster, I think at Academy, but not published as a paper just yet, that showed even use of the lipid drop through contact lens wear didn't blur vision and also still help symptoms. So that's a follow-up paper to watch out for, that you could actually safely use the drop in this case, which was Sustain Complete, as a lipid-based drop over the top of the contact lens without blurring vision and helping symptoms. And then finally, I'll just touch on that in-office thermal pulsation again. So this is Lipiflow. And there's a paper here that's been quoted widely, an important paper that showed a significant improvement in contact lens comfort and comfortable wearing time. So these wearers were symptomatic with lid issues. One treatment for in-office Lipiflow, and at 3 months, they had still 4 hours extra comfortable wear time. Now that's significant. When we're doing clinical trials for contact lenses up here at Core in Canada, to get 4 hours extra comfortable wear time is miraculous. If we get 1 or 2 extra hours, we are very pleased with that. So one treatment on lids in these patients who were contact lens wearers made a significant difference. Okay, so I think I've got 1 or 2 slides left, and then very happy to take some questions. So if we summarize all of that talking, and I said at the beginning, I wanted to be positive that we can do so much more with being proactive, looking at lids in these groups of patients and making a difference to these patients. So hopefully you can take that away from everything I've said. But absolutely, we should pay more attention to lid margins than I ever would have done when I first qualified more than 20 years ago in practice. There's much more we know, and there's much more we can do now. Interventions, both for dry eye and for our contact lens wearing patients, are pretty similar. And we can start simple, warm compresses, get the lid hygiene right and clean up the lid margins in office, give them more cleaning options to carry on doing at home to keep things as clean as possible. We can, in office, express those glands either with forceps or with a device if we have that available. Lipid-based drops have been shown to help as well. And particularly when we're thinking about contact lens patients, actually one thing I haven't mentioned so far, just coming back to extra bits of sort of thicker lipid knocking around, and the thinking that there's an increased mix of bacteria lurking in those glands for those particular patients, or perhaps on their lid margins, then it may be advisable in those patients to think about a daily disposable, fresh lens in every day, rather than a reusable that can potentially build up some of that bacteria on the surface needing to be cleaned off. So just bear that disposable option in mind as well. And I think with that, I will stop talking now, and I will just hand back, and we'll have a look and see if there's any questions. Thank you very much for your attention.
All right. So thank you very much, ma'am, for that wonderful talk. I think you covered from the importance and, going on to, of course, which is the most important, which is the management, right? So we need to know, once we diagnose, what's next.
What do we do? Yeah.
What they do, right? All right. One thing which I was a bit more curious in terms of when you were mentioning about the assessment part, you did mention that fluorescein dye, of course, will probably give us a false results in terms of using them used minimally, right? That's what you have suggested us. I was wanting to ask you on the use of Lissamine green. Do you use it regularly, or you use it only for a certain category of patients? What's your advice on that?
It's a really good question. Funnily enough, in Canada, it does not have a license for use. They don't like it over here. So we always have to get special permission to use it. Who would have thought that is the case in Canada? Back in England, I used it regularly, and we do use it for studies here. When would I use it? There would be a couple of situations. I wouldn't use it routinely on all of my patients. Absolutely not. I'm going to be using it in two situations. One is where I'm investigating a more moderate to severe dry eye patient, and I want to check the ocular surface for the integrity of the health of those cells in a different way to how fluorescein stains. So then I'm going to put Lissamine green in as well, because I want to better document the health of their ocular surface. The other place I'm going to use it is when I'm investigating lid wiper epitheliopathy. And that's often actually something for me in contact lens patients. And that's an interesting one, because when I would be alerted to looking for lid wiper epitheliopathy in my patients, or LWE, is where I have a patient that is finding discomfort with their lens, particularly towards the end of the day. And we've, if you like, pretty much eliminated everything else. Everything else looks great on their eyes. Happy with the lens, the tear film doesn't look too bad, there's very little ocular surface staining, and yet they still have symptoms. And I've also checked their lid margins. At that point, I'm thinking, is there a friction issue with LWE? And then I'm using Lissamine green to carefully then invert the lid after I put it in and have a look at the upper lid margin. What I would say for Lissamine green use, it is the opposite of my advice for fluorescein. If you're looking to stain for lid wiper epitheliopathy, 2 strips of Lissamine green, 2 big drops put into the eye. Give it a couple of minutes to settle. So you're putting a lot of Lissamine green in, waiting 2 to 3 minutes, carefully averting the lid, and then looking at that point. So you want lots of Lissamine green, generally for, or certainly for tear film assessment, little fluorescein.
Yeah, that's right. Yeah, that's the whole idea of starting. I wanted to ask you, because I faced some problems when I was doing Lissamine green staining, and I got to know very later in stage that 1 strip is probably not enough. You need to have more in there, right? So that's the exact thing what I was looking for. Yeah.
And it seems counterintuitive, because it's such a dark, vibrant color. You think you're going to be making a big difference, but no, you need to be generous with your Lissamine green.
Yeah, that's right. And let's just take some questions which have popped up on the chat. Any evidence which you think has shown on the Demodex being the potential cause for high Meibomian gland prevalence in elderly population?
What a very good question. And I haven't seen any direct evidence linking the two directly. There are things we know about that elderly population, that MGD will be much more common. And when we get to an elderly population, pretty much we understand almost everybody will have Demodex. So it's likely that the two will be present in the same patient. That's definitely going to be the case. They are thankfully just about living in slightly different areas of the lid margin. So we know Demodex like to burrow down into the eyelash follicle, not into the Meibomian gland. But of course, they're all very much in close approximation to each other. They're closely related on anatomically speaking on the surface, and they can both. I would just finish that up by saying, and they can both set up inflammation. So Demodex can, with the way that they excrete and burst on the surface and set up local inflammation around the eyelid. MGD, we know, sets up inflammation. So I think interrelated. I'm not sure that I've seen that evidence to specifically say Demodex can cause MGD in those elderly patients, but you're going to see both together.
That's right. Yeah. And I think this is a follow-up question, because it's again related to Demodex, and we use the oil. Is there anything which you would like to highlight on the use with contact lens wearers?
I mean, I would always, so you're not going to have the contact lens in while you're applying any of your diluted tea tree oil. It's an uncomfortable situation anyway, or it can be with some of those tea tree oil applications. But I would, and you know yourself, when you've used tea tree oil or a tea tree oil based substance on a patient, we know the vapor gets in the eye, it can be a little uncomfortable, and the eye can take a little while to settle afterwards. So all I would say is do it without the contact lens in, and you may want to advise the patient to wait an hour or so, or even through to the next day before they put their normal contact lenses back in. So I think just a little bit of common sense with that. But would I use tea tree oil if I saw Demodex in a contact lens patient? Sure, why not? You know, we want to, you know, if the Demodex numbers are looking too high, we want to reduce that. And one thing I will say is there is an association in a couple of studies with presence of Demodex being higher in contact lens wearers. We don't know why yet, but that's been found. And also that contact lens wearers who have dropped out of wear have a higher number of those have been shown to have Demodex compared to happy asymptomatic contact lens wearers who carried on. About 10% of those had Demodex. Of the dropout group that was looked at, this was Isabella Jalbert and Tarkowski's work, these two papers, but of the dropouts, 90% had Demodex. So it's literally a complete reversal. So there's definitely a link between the two. And if you see Demodex in a contact lens wearer, absolutely, I would treat it.
Yeah, that's right. And let's look at another question. Again, I think you emphasized this quite a lot in your talk already. But then would you want to give us some tips if there is a very primary eye care setup whereby I'm just assuming that we don't have those fancy equipments.
Exactly.
Like
Yeah.
How would you start going about in terms of what would be your first choice of treatment and then going further along the line?
So education, and I would also have something written down that I could give to my patient that reminds them at home of what I've told them about what their condition is and what they need to be doing. So education, I would do warm compresses. I would demonstrate that to the patient in the practice and have them take that warm compress home. If they need a lid wipe to keep things clean, I would also talk to them about doing that, and an eye drop. Something with a lipid containing eye drop. So as simple as that. In office, if I need to warm and then do that therapeutic expression just to try and get a little more out first time, then again, I would add that in. But all without fancy equipment.
That's right. Yeah. And I think the fancy equipment is just, as you already mentioned, it's just going to build up your practice. It's not really necessary to start a practice. It's a practice.
Yeah, I would implore you listening to don't make it a reason not to start. Don't look at all these talks you go to, and same for myopia control and everything. You know, if you haven't got access to all of the high level stuff that's being seen, and for dry eye disease as well, there's so many pieces of equipment for dry eye disease, for diagnosis and for those therapies. It can be very off-putting to think, well, I can't start because I can't access or afford those things myself. There are ways you can do great dry eye disease management, meibomian gland management, without having to do those kind of investments.
That's right. Yeah. Another question here is, would you consider a scleral contact lens with patients having dry eyes with minimum improvement with these dry eye therapies? I would rephrase that as therapies. So if your patient is not getting better with the therapies you have given, would you prescribe scleral lenses?
Yeah, absolutely. A really great option if you've got a compromised ocular surface that's giving pain, discomfort, and compromised vision. Protecting that with a scleral contact lens can improve the health of the ocular surface, comfort, and vision for that patient. So absolutely a great option. And we find some really nice recommendations in the recent BCLA Clear report. There's a whole paper on scleral lenses. There's an even larger paper on the medical use of contact lenses outside of cosmetic reasons. And both of those are great resources to highlight those uses.
Yeah, that's right. I think Clear report is something which has opened eyes for the latest available in many fields. It's not just the dry eye, but then, you know, if you read the report, you get so much of information, right? And I think you did emphasize also.
There's a lot to read, but they are open access at the moment. So you don't need to be part of an academic institution to or have an access to contact lens and anterior eye to access. They're open access, I believe, for a year. So if you're interested in looking at those reports, you can go to their website right now, to the contact lens and anterior eye website, and find the Clear reports, and the PDFs are available to download.
That's right. And I think with that, thank you so much, ma'am, for that wonderful talk and answering the questions and giving us the tips. And I think with that background knowledge, we'll probably go back. I think most of us should go back and start doing it if we are not doing management in terms of these patients, right?
Yeah, I used to ignore lids far more than I feel I should have done. I can at least say it was 20 years ago. Times have changed. We can do brilliant things these days.
That's right. Okay. So
thank you very much for inviting me.
Most welcome. And, thank you so much for doing the session for us. I do believe it's early morning, not very early, but it's kind of an early morning.
Not too bad.
Thank you so much. Yeah.
Lovely. Thank you very much. Have a good rest of your day. Thank you.
Most welcome. Yeah. So, I hope you all can join tomorrow to learn more about nystagmus and in terms of what are the clinical assessments to be done. Until then, take care, be safe, and bye-bye.